Hey, everybody. Um, I'm Peter Weimersheimer. I'm an emergency physician. I'm the VP of Education and Clinical Implementation at Butterfly Network, and really thrilled to host another of our monthly POCUS Power Hour webinars. So we host these every month. The goal is to do some aspect of point-of-care ultrasound to support clinical practice and to really enhance skills in ultrasound and adoption of ultrasound for clinical care. And tonight, we're thrilled to have four medical students because this is the next generation of providers who are going to take care, frankly, they're going to take care of me, I got to admit. But um, this, but as we talk about ultrasound, we talk about ultrasound in clinical practice. It does feel like one of the holes in clinical practice is that at the medical school level, there's a huge variation on training. Some students, like Ellie, as we'll introduce shortly, are getting a 4-year curriculum, and others are looking over the horizon at an ultrasound probe and wishing they can use for clinical practice with the recognition that this is a new technology and a new skill set to help them become better clinicians. So we're thrilled to have them and want to remind everyone that this is supposed to be interactive. So those of you who are attending, thank you so much for joining. We have a QA option and just ask questions. We have four great individuals who are really thrilled to discuss their version of ultrasound med ed. And the best part about this is I get to do this with Dr. Devinder Ramsingh, a colleague. So Devinder, why don't you introduce yourself and start it off?
Thanks, Peter. Yep, always great to do this with you, Devinder. I'm a cardiac anesthesiologist. My training support clinical research and innovation partnerships here at Butterfly. And yeah, echo everything you said. And here we are in the summertime, and I think June is that month of bliss where the graduates are going on to their next level, and then July, is the I don't know what you want to call it to be politically correct, but it's a month of stress and a lot of health systems because of the all the new trainees that are coming on board, and so great I think it's very timely to talk about it in at this level here, right, where the trainee medical students, how what that snapshot looks like. Peter, I think you said it so great. I look forward to that discussion about the in the US the exposure to medical schools on the topic of point-of-care ultrasound is widely variable, so it'd be great to kind of hear from our panelists about just kind of what that snapshot looks like in their own microenvironment. Love to hear the audience kind of chime in as well about what their experiences is today, because to your point, we all see that North Star of bringing POCUS to be truly as ubiquitous as a stethoscope. But how do we get there, right? And learning the tricks of what experiences everyone's had. I think we're all kind of big believers here. All the even our attendees are hopefully trying to get some insights. And so look forward to that discussion. And from that, maybe I'll just kind of hand it over to our panelists to introduce themselves. Just the first person on my screen, Alex, if you could just go ahead and kick things off, introduce yourself, say the level of student you are, where your your environment, and if you could say a few things about what got your interest in POCUS, as well as maybe just high level what the sort of POCUS education environment is currently within your school.
Absolutely. Thanks. My name is Alex. I'm a medical student going into my second year at the University of Vermont, Larner College of Medicine. I'm from Maine originally, but then I went to high school in Vermont. I went up to McGill for undergrad, and then I came back to Vermont for med school. And I'd say what kind of got me into POCUS was during my gap years, I worked as a scribe in the ED at UVM, and I loved it. And I saw how common POCUS use was, and how Peter kind of talked about this before the panel, but how it's like the moment where the physician can really put their hands on the patient and make that connection and just um kind of, hey, I'm looking inside your body right now and I'm in real time, I'm trying to help you and see what's going on. So I saw that, and then I got super into emergency medicine at that point. And then in med school, I'll talk a little bit about the POCUS education at UVM in a second. But I have been working with this really awesome rural EM doc named Ash Wiseman, and she's a super POCUS guru. And we've been working on a research project regarding rural POCUS use versus uh, like UVM Central versus some of the satellite sites. So that's been really cool. And in terms of kind of what the education looks like, I'm still in my preclinical, so I can only speak to that. But what we've had is about every couple weeks, we have a session through the POCUS curriculum where we work with a standardized patient. And so we started off with like, these are the basics of POCUS. These are the different probes we use, just the very basics. And then we went on and did some like basic cardiac. We did thyroid, DVT, abdominal, and just basically they were pretty short sessions, like 30, 45 minutes, where we got to work with a standardized patient and just kind of get a feel for it. But in terms of beyond that, it's very much self-guided, I would say. The library actually lets you rent out butterfly ultrasounds, which is awesome. So you can rent those out and practice. Um, and the staff at UVM, at least in the emergency department, which I've had the most exposure with, has been super open to just letting students come in during, like, for example, every Tuesday they have this system called Sono Tuesdays where you just go around the emergency department and practice ultrasound, as well as like some didactic sessions about ultrasound use. But it's very much, I believe, kind of self-guided if you're really into it. UVM has all the resources to get good at POCUS, but there's not, it's a super intensive POCUS curriculum at the moment.
Thank you for that. And yeah, Ash is she is a rock star, like as a clinician, as an educator. So great for you to be able to work with her. I'm going to go across country. We're in Vermont. Let's go out of California. And Ellie, thank you so much for joining. And you're at a different type of program. You're at the probably the oldest program that has an integrated 4-year curriculum, and you've had the experience of having that since you started. So I'd love to have you introduce yourself, maybe talk about that. Wondering if you knew about that before you applied to UCI, whether it had any influence on your application. But please say hi to everyone, and thanks for being part of this.
Thank you for the introduction. Hi, everyone. My name is Ellie. I am a third-year med student at UC Irvine. Before college, I went to UCLA. I took 3 gap years. I did some traditional pre-med things during that time, but now I'm happy here at UCI. So it is true. We have a huge ultrasound focus in our curriculum here, and I think that did draw me to my application to UCI. Of course, when you're a pre-med and you're applying, you kind of apply anywhere, but of note, they did say that they did have an ultrasound curriculum. And at that time, honestly, I really didn't know what ultrasound was. I knew you got one if you were pregnant and they wanted to look at the baby. But that's kind of as far as I got. So I was like, oh, that's interesting. It's strange that they actually note that. And so when I was admitted and during orientation, I think faculty and other students were super excited to talk about that because, like, it's funny, they give us all ultrasounds, and I literally have mine with me today. And so they get really excited about it and all the opportunities. And I was like, wow, I'm really excited about this too. So I joined the ultrasound interest group. And then our curriculum is, I guess if you don't like ultrasound, I'm so sorry because every week we have to ultrasound. But I liked it. So it's very integrated. They teach us everything. There's lectures behind like the physics of ultrasound, the history of ultrasound. They teach us the skills for ultrasound. They teach you the pitfalls where you can go wrong and all that. We have standardized patients that we get to work with, and it's like a 2-to-1 ratio. So 2 students, 1 standardized patient. So you get a lot of time scanning. And then it is a 4-year curriculum integrated. So right now in my 3rd year, they actually have me. They have assignments for me where I scan my real patients. Like today, I literally was getting a parasternal long on my patient to try and fill this assignment requirement. So I think that's really cool because it kind of bridges the opportunities to use ultrasound in the clinical environment as well. So I really appreciate, I know how much UCI wants us to use ultrasound in our career. So it's definitely a very appealing aspect of this medical school. And, it's really exciting to make the most of it now that it's here.
Ellie, thank you so much. Peter, what do you say we go to the middle of the country then now with our last two panelists? Jazz, how about a quick intro here, and love to get your background.
Oh yeah, sure. So not exactly the middle of the country, but I feel like the middle of, rural American medicine. So I'm in upstate New York, about 45 minutes away from Ithaca in a small town called Elmira. It's a really cool place. I've loved living here. So I grew up just north of New York City, came up north here and went to Cornell for my undergrad. Then moved back down to the city into Brooklyn, and for 4 years was working in imaging. So I worked at Mount Sinai at the School of Medicine in the biomedical engineering and imaging department. And I was managing the preclinical nuclear imaging facility. So I like to think that I was kind of like a baby sort of mini version of a radiologist, but only with animals. So I was in charge of doing PET CTs, MRIs, ultrasounds, and a couple other imaging modalities on everything ranging from mice all the way up to monkeys. And that was where I got my first exposure to ultrasound. So admittedly, when I had started doing this research, when I had this job, I was doing lots of cardiac imaging, and I was doing mostly MRI, but then some ultrasound. And when it came to ultrasound, I kind of hated how efficient it was, because instead of sitting down and waiting for a scan to run for an hour and scrolling on my phone or doing research, I could get through all 10 mice for the day within an hour. And when I started asking around to the researchers, and I was like, admittedly, why are we not just using ultrasound? Why are we doing MRI where we got to come up with, run 7 scout scans to get exactly the right plane, and then the limitation on the analysis at the end of it, whereas the ultrasound itself has all these incredible built-in Doppler systems and everything else. They were like, just because in many ways MRI is the standard of care, and in translational medicine, we really want to try to line it up so when we go to get grant funding, it is as one-to-one as possible. So that was my first exposure to ultrasound. It was grossly positive, but I didn't quite understand why. I could get wall motion abnormalities, I could get ejection fractions, I could get a million things within a 5-minute scan. And I also come from kind of a love of music, and so the whole sort of sonography aspect of it, I loved that it was wave-based and could get a little philosophical with it. I worked there for 4 years and then moved up here to Elmira to start med school, and now I'm a third year, so have finally made it past my preclinical sort of experience, and sort of re-entering my skin again, taking control, because I had 95% of my brain was partitioned for first aid and Anki, and now I'm remembering all the things that made me smile. So that's a lovely time. But 2 points of banter, I guess, about clinical sort of experiences and starting off in rotations. It's interesting to hear Peter say, an EM doctor saying, "I'm so glad we have 4 med students here," because you rarely will ever hear that in the emergency room, except for him. He's a great great educator. And I want to go into child neurology. So Peter before commented about how he can't wait for us to be taking care of him. So I know that in child neuro, I'll be certainly seeing him in my office. Ultrasound has been really interesting. And to give you a little bit of a picture of where ultrasound exists at my school, it doesn't at all. We have no POCUS training whatsoever. And it's bizarre because everything is aligned for it to take over. I mean, we're in a rural facility where we're going out on sometimes clinical rural vans to go out and help people in the community. Hospitals around here will have either 1 or 2 low field MRI, not low field like cool low field hyperfine stuff, but just like a 1.5 Tesla sort of MRI scanner, or 1 or 2 Healthineers from Siemens in the CT world. And so it seems to me like this is the perfect opportunity to be employing ultrasound at the bedside. And as I've been starting off in my rotations, I've just been seeing how many opportunities would have bettered clinical care, both for diagnostic aptitude, but also just the time that a patient had to spend in the emergency room. I mean, a couple of weeks ago, I spent some time in the ER, and there was a patient who had to wait there for 5 hours to get an abdominal CT, when all they really needed was confirmation for documentation that they did have an abdominal hernia. I was like, if I just had a probe on me, man, I could stick it on there and we could have this person out in 5 or 10 minutes. So it's kind of like not checking out the stethoscope or saying, I don't know. Tourniquet seems a little advanced for me. I prefer the old method of just sort of jabbing, let the blood squirt. I want to take the luck aspect out of medicine. I want to try to be as precise as possible, to try to be the best physician possible for patients.
Jazz, you're forgetting leeches.
And leeches,
You're
bloodlettings
forgetting.
were pretty awesome. Yeah.
Correct.
But I want to place
Yeah.
that leech directly on the brachial artery. I don't want to have to guess whether it's off a little bit.
Well, thanks for that. And we met at ACOM, and yeah, it's hard to hear about someone or a class of learners who are really enthusiastic about becoming clinicians and don't have an opportunity to harness the technology in their learning cycle. And I guess with that, the last but not least is Mason. Thank you so much for joining us. Mason, you're at KCU, and I know you've been involved with a program that's gone from a small student elective to a large student elective to now a one-to-one model. So you've been there for that evolution, and you also were there through the evolution of trying to use Butterfly Scan Lab as an asynchronous teaching tool, and had the experience of. I looked at your studies, Mason. I know what they look like. Right. So
Okay.
they had the experience of having that type of educational cadence. So please, thank you again for joining us, and thanks for bringing your friend in the background to join as well.
Yeah,
And
Slim back there.
yeah, so please introduce yourself, talk a bit about yourself, and love to hear a bit about your experience at KCU with as you've been really present through an evolution of nothing to something, and some enthusiastic faculty supporting your journey.
Yeah, thanks, Peter. First of all, sorry for all those threes on there for the cardiac. I'm sorry you had to see those. But so I'm from Marshall, Minnesota. I went up to college at Concordia in the Fargo-Moorhead area. I was an EMT up there, and then took one gap year and was a phlebotomist. I had zero exposure to ultrasound prior to med school. I was in the same boat as Ellie, where I thought it was primarily for just pregnancy stuff. And got to med school and was exposed to the ultrasound club from the class above us my first year, and thought, oh, this is kind of cool that we can do some other stuff and we can see different parts of the body without having to do CTs or MRIs. And so then I was the curriculum coordinator our second year for the club, and we just tried to expand it and kept on going. And it was kind of the perfect time when Butterfly was coming out with the AI scan lab where you could teach yourself. And I just really wanted to get it in the hands of everybody at the school so that everybody could learn on their own. We're the generation of we know how to use the internet and we know how to use technology. So I figured if everybody could get their hands on it, they'd be able to figure it out. And with Dr. Arntz, the EM doc at our school here, we were able to build that curriculum, and it was an elective this last year. And we had over 400 students in it, and everybody bought their own probe to use for the class, and then the class was included with our school. I think we had over 15,400 scans done in the past year was the final number as a whole collective school. And we used the Scan Lab app with the quality bar and the reference images to just kind of learn and learn as we go. And as I went through third year, I brought it on all of my rotations, and I just continually asked my preceptors, hey, can I just go take a look at this? Or there was just so many times where we were actually able to save them from a formal ultrasound scan or from a CT, and save the patient a bunch of time and money. So it's been a really unique tool to have, and it's cool to see the progression that we've made with the course. And now, like Peter was saying, it's a one-to-one program. So the first years coming in right now, they all got their own probes, and we're basically going to make those electives stretched out into the first 2 years before they get to clinicals, and then they can learn on their own after that. So it's been a really cool process.
Yeah, it's been a pleasure working with you all kind of virtually. I have a question for you. When as you've been aggressive and you've been scanning in your clinical clerkships and externships, what's been the response from when you've had faculty, for instance, who weren't good at POCUS and you said, I'd like to scan? what do you get support? Is there a barrier to scanning with faculty members? What's been your experience in that spectrum?
So some of them, there hasn't been really anybody that's been too hesitant with it. They'll see you a couple times, or maybe they'll want to see you scan once or twice, and then once they see that you're pretty proficient and know what you're doing, then they feel a little bit more comfortable with you going in the room on your own and scanning patients on your own. Like I was in a peds office and had a girl that just had a cyst on her cheek, and I was able to go scan it, see that it was perfectly fine and just a simple cyst. And she said that she would have ordered a formal ultrasound for that. So even in peds, I was using it. I was bringing it along with me, and I mean, I've scanned gallbladders that we took them straight to surgery rather than getting a CT for them. It's just been it's been a good tool to have. I mean, there's some people that they don't see the utility for it, or it just takes time and they got to move throughout their day, and that's fine. But it's been a pretty good response. And as far as faculty that don't know what they're doing with ultrasound or haven't had the training in ultrasound, with the ScanLab app and with the way that we have the course set up, you only need 1 or 2 faculty to run it. And that's been one of the strengths of our program.
Yeah, fantastic. Now we definitely hear when we're with different medical education groups that, there's faculty who, when they're on an externship or clerkship, are basically refusing to let students scan. So wonderful that you get that opportunity. Alex, I'm curious, as you're working in, this is your first year and you had the experience of working in rural medicine. Would love if you can share a story or some anecdote about what ultrasound did in the rural healthcare setting, and curious about how your peers are perceiving. They're all, again, you have an ultrasound training that's focused on the basic sciences or the integrated curriculum, but then it's a self-generated. Is there a perception for yourself about students in terms of what would they prefer, or is that a detriment in how they perceive their education? So, A, great, tell us a story, and B, what's it like when you're in a group of students who get a bit of training, then all of a sudden they're kind of on their own?
Yeah, I think one of the coolest things I've seen ultrasound used for, and I know it's not super uncommon, but it was one of my first experiences in the ED, was just popping an ultrasound on the eye to look for vitreous detachment or retinal detachment. I thought that was super cool. And then actually a couple weeks ago, I went to a didactic session with the EM, like grand rounds, and they were going over what they're looking for on that ocular ultrasound and how you can tell the difference between vitreous versus retinal detachment. So I think that was pretty awesome. In terms of how my peers are um, conceptualizing the ultrasound program here, I'd say it's kind of a mix. I think there's a decent amount that just don't know much about it, and therefore when we have this ultrasound sessions, they may just like kind of skim through like the pre-work or like the videos that are explaining what they're looking at. And they go in the session, kind of fiddle around with the ultrasound for a while, try and learn a few things, but it's definitely not at the forefront of their minds. Then there's a lot of the ones that are interested in emergency medicine or similar who are like super into ultrasound, and have been renting out the butterflies from the library, which is what I've been doing as well, which is super fun, and just like really trying to get as much experience as possible. But it's definitely a mix, and I feel like anyone who wants to know about ultrasound has the opportunity to here, but they may have to really. It's hard to get that motivation when we only have those little chunks every 2 to 3 weeks where we learn a little bit about it. And I think a lot of my peers maybe don't understand how useful it is in all sorts of situations and the variety it offers.
Alex, thanks for your insights. I think, definitely want to get back to those points and the points that were made earlier about, yeah, in the current education environment of getting these, brief moments of exposure to the topic. How do we expand that? Maybe the value of, based on your experience with ScanLab or other asynchronous learning tools, definitely want to get there, to kind of have some time to talk about that use. But let's just want to get another snapshot of a different environment. Ellie, it was mentioned already that UCI has been on the forefront of adopting a one-to-one POCUS model for many years now. But curious to see what's been the experience with you on your clinical rotations, just even again in that environment where POCUS has been around for a good bit. But practitioners who've been out for a significant period of time, what has that environment been like for you as a student? In sort of that other end of the spectrum, where hopefully most of the clinicians have at least heard about the topic, used it. What's your experience been?
Yeah, I mean, like I said, I scanned someone this morning, and I think because UCI is so big on ultrasound, most of the faculty are like, you know how to do this. So they're like, where's your butterfly? I'm like, okay, let me pull it
Wow.
out, let me hook it up. Like literally my resident was like, you guys should just go scan your patients just like for fun. And I was like, you know what? I got downtime, so I might as well. So it's really interesting because, obviously we're not going to use it for the medical record or anything, but it's fun because, you kind of get that instant gratification. Like I want to check a mitral valve. I want to look at if this person has like any ventricular dilation or anything or hydronephrosis in the kidneys. I'm just going to put my ultrasound on there and get a sneak peek before the actual ultrasound tech comes around to give us like the one that goes into the patient's chart. It kind of expedites like a whole chalk talk and like learning experience during rounds and all that, because it's like, oh, I have a question. Do they actually have the hydronephrosis? Okay, let's check. This actually really looks like hydronephrosis. Anyway, so let's think about our management right now before the actual read comes in, and then we can kind of preemptively start thinking about the plan before waiting around, because sometimes ultrasound techs get a little busy, you won't get a read till later this afternoon or tomorrow. So at least I'm thinking about the plan before that even happens. It kind of expedites patient care. But yeah, I mean, like I said, faculty know we know. So even if we just get the reads or like the scans on the chart, they're like, you want to read this? I'm like, okay, I guess I'll read
Wow.
this.
That's
But yeah,
that's
it's
really
crazy.
interesting to say. Yeah, they kind of hold that as an expectation. And also you hit a good point about the concern for the trainees. Like I think UCI system is very elegant in that all those images go to a completely separate administrative database that's archived as for educational use only, that can get QA'd and give you that feedback, but doesn't go directly into the clinical reporting system. And so really elegant matrix to be able to use and leverage technology to be able to get you the opportunity to do those clinical scans, maybe even accelerate care, like you said, especially in an environment where they're actually asking you to do it, but still, put some guardrails up. I think, yeah, it's really, really, really kind of great, Peter, to see the wide variety of exposure to at the student level, right? And your insights on just understanding kind of what to do next, right? Like, maybe we want to go in that direction about how do we bridge that gap, right? And we've already gotten this experience of such a wide variety of exposure to to the people that have already come in on this. What's how do we make this a little bit more uniform across the healthcare education landscape?
Yeah.
It's open to anybody. If anyone, yeah,
Yeah,
Jazz,
yeah,
please
yeah.
feel free.
Jazz,
You
Jazz,
can
we
take
have
a lot of this.
nothing. How are we going to get to
Yes.
something? That's the
Yeah, because I
Yeah.
have nothing to contribute here, so I might as well talk about where I can go
Yeah.
here. No, the reality is that I dropped like $3,000 or $4,000 in textbooks that were virtual, that I can say now that I've passed step and level, I never opened once. It was just a forced line on my, my med school tuition and the loans and everything. And so, we're all going to go online and use Bootcamp or Anki or any of the other resources that we have, which have already become unified. That's kind of the interesting thing I think about our generation of med students, is that, at first when I thought, oh, I was hoping to go to school maybe in a big city or at a, big academic institution, I ended up in kind of a more sort of rural place. And so, your first thought is, am I going to get a education that is equivalent to someone who is maybe from a school that's existed for 100 years or whatever? And the reality is that our generation has unified everything. So we are all studying off the same Anki decks. We're studying from the same online things. When we go and sit down for step or level one, if you're a DO student, you have used the same resources to get there, and therefore are really kind of in touch with the same kind of information. So why not have that same type of unification in education extending out into the clinical skill set as well. And that's the biggest thing that I garner from this is, I'm really jealous. You guys have had this exposure here, and I desperately want it too. So the question is, from Butterfly, and as we're all sort of getting it together, is it possible to do month-to-month rental programs? Is it possible to do leasing? Now we have this AI online-based learning platform. Can I do it from home on my roommate or on my cat, rather than if I don't have access to going to a big hospital and doing these things. And it's an interesting future. I mean, I really like, Ellie, what you just said about like, why don't we just check if they have hydronephrosis? I think the hardest thing that we have to do in medical school, and I'm sure that Dr. Ramsing and Weimersheimer have had this experience too, is you move from these first 2 years where all of the information is given to you. It's up to you to make a determination based on, you have all of the information to answer the question correctly. You may not remember it all, but that's totally cool. So, how do we get that same level of patient is a 37-year-old woman who presents with hydronephrosis, she presents with this, and that, and then, answer your question for the next best clinical outcome or the next, thing that you have to do in the treatment plan. How do we get that kind of information immediately in a similar way so that we can answer real life clinical scenarios in a similar way that we're trained to when we do our 10,000 questions before sitting for one of these board exams? And I think that ultrasound is one of those ways. I mean, you can get immediate feedback. You can immediately understand something. I mean, for us, I also go to a non-cadaveric school, so we didn't have any cadavers. So when it came time to learning anatomy, it was all based in this book that I hope none of you guys have ever had to look at, but Rowan's Atlas. It was like the bane of my existence for 4 or 5 months. The reality is, if I had an ultrasound probe and I could have looked at all of these structures for the first time through that lens, that's like learning the cardiac cycle, but at the same time doing some, auscultation too. You're associating the presentation with the condition, with the pathology, with the anatomy. And so if that is rooted into the education system right from the beginning, then ultrasound and the butterfly probe in our pocket becomes that secondary. We're outsourcing our brain right to it. We're outsourcing our eyes, outsourcing a sense. And that is kind of what I'm looking to get out of the education once I'm able to receive and sell enough of my own internal organs to be able to buy my own butterfly.
Dude, if
Yeah,
you sell a kidney, you'll be fine with a butterfly.
Oh yeah, you get multiple.
Devinder, you may relate to this thought, but I've been an attending and instructor for about 30 years. And when I was listening to Ellie and yourself, one of the things that struck me, Ellie, when you describe, when you're talking, when a attending physician is asking you to do a scan, is the concept that part of medicine is the see one, do one, teach one, and you have the exalted clinician who's teaching, but there's a generational change in how we think about the world. There's a generational change in how we do things. And the fact that Ellie is in an environment where a mentor who has a wealth of experience and clinical skill set is reaching out to a medical student saying, can you do this for me? Can you give me the answer on this patient? It feels like it changes the relationship in learning, where you have someone with a lot of skill set who has a lot of information to impart, but is recognizing that the second generation is coming up and has information to impart backwards as a teaching tool for the attending. And Jazz, as your enthusiasm and experience with imaging and not having the opportunity. And then, Mason, I'll divert this to you as you have that same experience where you're now going to rotations where you are working with outstanding clinicians, outstanding mentors, but you're offering them almost a reciprocal gift in teaching. And I'm curious what it feels like for yourself as a student. I remember being a student and getting not tired isn't the correct word, but having I'd like to have recognition for my skill set. I'm a person. I'm learning. I have insights, but I'm often in an environment where I'm being taught to versus in a shared decision-making environment. And it feels as if that ultrasound in the student spectrum allows you as a student to have a little more say and a little more authority in your learning. So I wonder if you can elaborate a bit on what that has felt like for you.
Yeah, especially going into third year, I was just made the most terrible plans right away. I had no idea really how to practice medicine or implement what I had learned in the first 2 years. We got there eventually and continue learning on and on. But to have a skill set that I feel pretty comfortable in was invaluable during third year. I mean, just a couple days ago, had a guy with history of kidney stones that he was sitting in the department waiting for a CT. I put a probe on him and was able to see some moderate hydronephrosis, and we were able to just get him out of there quickly because he already knew the drill for what to do. So it makes me feel a lot more comfortable talking to patients and being able to scan patients and just knowing where to put the probe and being able to get high quality images. Just makes me a lot more confident third year. And that was the biggest thing coming out of it.
Do you feel like your attendings who were not scanners had a sense of that contribution? What was it, what was their version of you being there with that probe and doing the scanning?
Yeah, I've had a lot of ED rotations lately, so all of them kind of know how to scan. The one that I keep going back to is the pediatrician with the cyst. She had no ultrasound access, was gonna send them out for a third-party scan, and was really grateful for me to be able to go in there and do that. I just did that on my own too. I just was like, I'm gonna take a look at this and see what's going on. And before I had even presented the patient to her, I had that scan to show her, and she just took a screenshot of it and put it in the chart. So it works out really well when you're able to add something to patient care that is not already there. Especially that was in a pretty rural environment too, and that's where I'm hoping to practice with ED in the future. So it's something that you can enhance patient care with as a third year and fourth year medical student.
Wow. Mason, I appreciate those insights. It's funny, when you hear about the students learning about POCUS, no one ever is questioning the value of POCUS as being a useful diagnostic tool, right? The second you learn it and you get exposure to it, wow, it helped me detect this. Otherwise, when I couldn't detect that, and that's great to just literally never encounter that environment for students to feel like it's not a useful area for them to explore and to learn on. And it's great to hear that, maybe, Peter, to your point, and to everyone on the panel, to say, wow, maybe that trainer environment is changing, that it is more bidirectional. And it's so great. And I encourage all the people listening in to be able to say that, hey, that environment is there. The topic of POCUS now has well penetrated across the US and abroad, so that even if you're talking to a clinician who's many years post-training, they know about the topic of point-of-care ultrasound. Now, to everyone's point, they probably don't know how to use that specific modality for a specific scan and things like that, but they at least have the awareness on its value. And I highly encourage, again, everyone listening in, to say that you are at that stage now where if you get that exposure, you get that experience, and you just try to go out of your way sometimes. Again, all of you, I think, on the panel have done that, right? You've gone out of your way to try to learn the skills, demonstrates of you. But for the most part, it sounds like you've been met on the other end of that positively, right? And I just, re-echo everyone's statements here on the panel for our listeners to say, this is that inflection point. This isn't even, Peter, what it was 10 years ago or even 5 years ago. I think more and more we're at that stage where people know the shoe is going to drop. More and more people are going to be expected to actually pull out an assessment tool that actually sees inside the body, not just listens and makes everyone pretend that they know what's going on, right? Everyone knows about the wonderful studies that, I can't help but cite the studies published in a Journal of American Cardiology comparing cardiologists to medical students, when a cardiologist, with 10 years post-training evaluates with their stethoscope for structural heart disease versus a medical student who had 2 weeks of ultrasound training. The medical student by far and away beats the detection of every type of structural heart disease compared to that, 10-year post-training cardiologist, right? And again, it's because of that higher diagnostic efficient tool. And so, again, just the saying of comments and restating to everyone listening in that this is that time, right? Take the interest to go and get those exposures. I had a sort of pivot from that. I am curious about Elaine, about, it was mentioned a little bit about, wow, you see the value. And I wonder, how has POCUS or point of care ultrasound helped you learn other aspects of medicine? So in other words, like, do you feel that with the integration of when you're now seeing organ systems and things, does that actually help with your understanding of pathology and things like that? I'd love somebody to comment on just kind of how, if you're in that curriculum, great. If you're not in that kind of curriculum environment, where you think that could be of value. So maybe Ellie, if you could first comment on just kind of, since you have a very integrated curriculum, and then we can just go down in terms of, like, sophistication of your ultrasound experiences so far in your school.
Yeah. So that's the really exciting part, I think, because sometimes there's a lot of resource overload as a medical student. You're getting all kinds of different perspectives on how to attack medical school, how to study. But actually, one of the most useful things is ultrasound because it's another way of looking at the body. And especially in first year, when we're in preclinicals, we do organ systems. And it kind of aligns with our anatomy course. So we do dissections in anatomy. So say we're in the cardiac section, we're going to pull the heart out and we're going to dissect the heart open. We're going to look at the ventricles, the atrial, the valves. And then we go to our doctoring class and they're like, all right, you're going to learn about cardiac ultrasound. And they show us, like, okay, turn the probe this way, turn it that way. Here's the atria, here's the ventricles. And then you kind of sit and think and you're like, I'm thinking back to my dissection where I held the heart in my hand and I'm rotating the heart in my hand. I'm thinking, where would I put the probe? Where are the rays going? So I think having that integration with anatomy was super important, not only for learning the anatomy, because on ultrasound, it's kind of like, here's another way of looking at it. Here's a slice. Now you can really remember from this picture that these are the atria, these are the ventricles. But when you're learning the ultrasound itself, having the anatomy in your hand helps you visualize it in time and space. Because I think one of the hardest parts for new learners to ultrasound is kind of understanding where the beams go and like how to visualize in your head what I'm actually looking at and from what angle. So I think, like, in schools that do decide to implement ultrasound, it is a great idea to kind of focus it system wise and maybe try and align it with any anatomy curriculum that might be at that school.
And Alex, you had the experience of, as a first year, you're in the basic sciences, you're dissecting, and then you're working in a rural healthcare environment with a probe looking at things. And I'm curious how that, what that did for you in terms of thinking about how ultrasound would affect care, when in one sense you're dissecting, you're in Ellie's world early on, where it's basic sciences, you're learning histology, you're learning pathology, you're dissecting, you're getting some basic clinical skill set. At the same time, you're working in an environment where you're doing a visual aid to do what they're teaching you in a non-visual environment.
Yeah, absolutely. I just want to say first that I'm very jealous of how complete Ellie's ultrasound program is over at UC Irvine. That sounds amazing. And I guess in terms of comparing like anatomy dissections and ultrasound use, they usually lined up the ultrasound sessions with the anatomy we were learning, which was helpful, super satisfying. I think one of the coolest ones as a first year medical student when I don't know anything, I'm still a rookie, was learning how to test for DVTs in the popliteal vein, because that's something that's, well, can I compress it or can I not compress it? That's something super easy, and suddenly, wow, I would be able to diagnose that with just this tool and 30 minutes of training on that, which is super cool. But definitely in terms of rural use, I think something I've seen both in person and through like the research which I've been doing is just how some of these hospitals just do not have formal ultrasound at all. Like Elizabethtown or Ticonderoga, they either don't have formal ultrasound or they've got like maybe 2, 3 hours a day with one ultrasound tech for like pre-planned scans. So when you're out there by yourself, it feels like either you have the skill set and you can use that point of care ultrasound and you can save them from a CT or from from admission or from getting transferred, just by having that skill set and being able to pop the probe on them for 10 minutes. So that's probably one of the most useful things I've seen, and it's been sparking my passion to really get good at it. Because hey, if I'm stuck out there in the woods and I've just got an ultrasound probe, I want to be able to use it and make decisions based off of that.
And it's amazing how it changes people's lives just by be able to look. We actually have a few questions, so thank you, those of you who are attending and
Yes.
listening. This has been really great to have you with our panelists. The first question, and I guess we can do Jazz and Mason since you're both in burgeoning. We don't have a program, or we're getting a program. It's my school doesn't have an ultrasound program. Where can I start? How can I advocate? And so, Mason, you have been at a kind of more successful stage of advocacy, and Jazz, you are a passionate advocate. So if you both would, it would be great to chime in on this question and just give some insights for the challenges for those who don't have what they would like.
Yeah, for sure. The biggest barriers that we've had with starting POCUS programs have been the number of faculty that you need to have, and then there's not enough room in the curriculum, there's not enough machines, and we got a lot of student support in order to bring the AI program to KCU. So I went around and I collected surveys along with the president of our club, Chance. We got surveys from the students that said we want more ultrasound. We want ultrasound in the curriculum. We just got a lot of support, and we took that to the faculty and said, this is possible now, and we're able to break down all these barriers to it. We only need one faculty because we are going to outsource the grading of scans to Butterfly so that we can get grades on those and we can see student quality of scans. We only need one faculty to actually teach the course because we don't need someone looking over your shoulder every time that you're scanning someone to say, hey, you need to move this way or that way. And in order to get a better quality image, they can look at the feedback that they get from the scans that they submit. And then just keep on it. It took a lot to actually get it to the point where it is right now. And once we got it over that edge, once we got everybody the probes, it just took off. And now it's integrated into the curriculum after just a year. So just keep on it. Keep voicing your opinion.
Yeah, I think that Mason gave a really good sort of tangible idea of how to do it. Collect surveys, go do everything. I mean, medical education is changing with every year. So many more schools are just opening up. And so at some point, it doesn't feel like it when you're applying, but you have a service to offer the medical school. They want quality applicants. And so you have to be able to advocate for the things that you need. And in going to these conferences, the conference where I met Peter, I was there presenting with my dean about generational differences in medicine and how a lot of older physicians will label our generation as anxious and as uncertain in their practice of medicine, and talk about the development of professional identity. And the reality, I think, is that, in today's and I'm deviating from the question slightly, but I think Mason did a really great job of covering it already, is that we live in a litigious society, of course, and so physicians themselves are going to be a little more hesitant to let you do something, place a chest tube, place a central line, whatever. So where can we assert our use? How can we be beneficial for patient care and have a job, have something that they look to for us? And I think ultrasound is the perfect way to go about that. I right now I'm on rotations and I'm at a state psychiatric facility. And you might think that a psychiatric facility probably isn't the best place for the pathologic sort of, plumbing issues that sometimes ultrasound can be useful for. But I had kind of an interesting experience today. I have one patient who has illness anxiety disorder and somatic symptom disorder. And when he is rattling off so many things that he's uncertain about, I have a kidney stone, I have migraines, I have dental abscesses, I have this festering sort of furuncle that's on my left butt cheek. I've got all of these things. And as a provider, we're all sort of trying to figure out, like, gosh, how much of it can we attribute to real pathologic issues and how much of it can we ascribe to his underlying mental illness? And I was like, this would be the perfect use case for ultrasound. You could say, all right, buddy, what's your main concern right now? I'm concerned about kidney stones. All right, here we go. Lay down on this table. Pop it on. Biofeedback immediately. So I will feel better because I know he doesn't actually have, kidney stones, and I'm not, not treating something because of a presumption of the mental illness. And he will hopefully feel better because he has immediate feedback that that issue is not pathologically there. I mean, we need a way to sort of cure that litigious anxiety. Am I doing enough? And ultrasound is not a disposable thing. We don't have to waste any hospital resources in order for us to learn on it. Just a little bit of jelly and the probe in your pocket, and we can learn, hopefully give something to the clinical picture, and become better physicians. So continue to advocate for it at your schools, but also I think like right now only like 20%-ish. I might be wrong on this. I just remember hearing somewhere 20% of schools don't have ultrasound education. That might be slightly off. So pretty soon, if we make this an important enough thing generationally, and we say, no, we would rather go to another school because of that, that forces their hand. And I think that that's at the point of administration that we need to start getting to. We all need to have this skill set.
Yeah, it's a really profound answer. And frankly, Jazz, there was a question to you specifically about if you had the choice between going to a very prestigious school versus a non-prestigious school, but you had a 4-year curriculum, would that influence your decision? And we can certainly pass around. And I will offer, as a seasoned clinician, that people forget the power of what a negative result does for the person you're taking care of, right? So we get it's really profound. Like you see some really cool, like fascinomas, right? To gather around a patient, you gather on an image, you say, wow, look at that. Obviously that's affecting somebody's life. But to your point, as you're going to a pediatric specialty, most people have negative findings, but they have real concerns. And the power of being able to put, in this case, for instance, an ultrasound on a kidney and saying, there's no hydronephrosis. You watch people's shoulders just melt and their affect just relax because their fear of a catastrophic pathology is gone. So the question at hand, it was asked to you specifically, but we'll pass around afterwards. If you had the choice between the highfalutin school and a lowfalutin school that ultrasound, what would you do?
Yeah, it goes back to what part of being a physician matters most to you. So is it getting the Porsche keys in your pocket as soon as possible? Or is it being on an airplane and having someone collapse and you actually stepping up and saying, no, I can help here? For me, it has to be the skill set. There's like a thing from one of my favorite movies, everyone gets paid in the end, but the fools get paid first. And I think it's foolish to try to chase prestige rather than training. I think, nobody is gonna, if there's an emergent case or a code called and you rush into the room, they're not going to say stats in school first. They're going to want you to put hands on the patients and be able to help as quickly as possible when a life is at stake. And this is that kind of skill set. So, I want to hear everyone else's opinions on it, but I think that this really matters, and people in our generation are super excited about POCUS.
Yeah, Jazz, I echo your thoughts. Like, I think really the time is now, that your point about it truly becoming a new standard. And, Mason, your point about talking about how you got started, and Jazz as an advocate, I think two thoughts that we've gotten experience and other folks giving us weighing in here about getting the data from your local environment, right? Yeah, Mason, you talked about doing a survey, getting that information, and then presenting that to the leadership to say, hey, look, this is an interest to our student body via data from these surveys. We need to do something about it, right? I think that's a great way to kind of get exposure to the earlier question about how do you get started. Well, one, prove that's a problem, right? You can talk about these, anecdotal values and things like that, but if you can, there's definitely hard data you can generate from students. And Jazz, to your point, I think there's enough passion amongst students now that survey will unanimously probably be very positive to try to support it. I think there's two questions here, Peter. I'll answer those quickly because I'd like to try to finish off with our standing point about leveraging technology for the learning environment, because I think that is an area that I think hopefully will be a major unblocker for the current environment of where we have to have these training models that are very hands-on, very labor intensive. But now technology potentially can help improve that, especially to the learning environments now where you guys already do so much asynchronous learning, right? Often you go to the question bank first before you go to the textbook, right? Which is the opposite of how I went, when I went through school. But so just very quickly, the role in Focus for Global Health. The one-liners here, 2/3 of the world does not have access to medical imaging. Point-of-care ultrasound is the only solution that is actually transferable across both, high income and low income environments. And, it makes you a better clinician no matter where you're working, whether you're working in the most prestigious hospital or out, in the most rural environment. Envisioning portable ultrasound, leveraging the ability of an all-in-one chip-based solution to be able to evaluate the body comprehensively from a single exam tool is the future of ultrasound. Whether it's a butterfly solution or not, it is the idea of portable handheld ultrasound, just like you use your stethoscope. Chip-based ultrasound allows you to do that today, but the future is super exciting, right? And that's exciting. So last one, do you think shadowing ultrasound techs in the local hospital system, increasing opportunities? There's environments. Ellie, I know there's an environment there where they have sonographers that will go around with individuals to be able to support the learning environment, and that's definitely a strategy to help support medical schools or any training schools. In fact, many sonography schools actually have a peer-to-peer model where they actually do the exact same thing. So sorry, rapid fire here because we're coming on time, Peter. The questions always come in towards the questions always come in at the end, but you can feel the energy and I'm so thankful for attendees. Want to first, hopefully this was useful to you listening in to get some insights, from our panelists. Very thankful for our panelists to give your time and share your experiences. Peter, I'll hand it off to you for closing remarks, and then maybe we can give our panelists a chance to talk about, the AI and future of education.
Sure. I will say that one of the really profound things about working with sonographers is that in many systems, sonographers aren't really allowed to talk to the physicians or the providers who are taking care of the patients. They have to scan, they have to talk to the radiologist. You ask them a question, they kind of look at you and go, I can't. But when you ask them to teach you about scanning, they open up and are phenomenal educators. So these are all really gifted scanners. They have great education on how to do image acquisition. They are limited in what they can teach about interpretation, often by law in terms of the medical system they work in. But if you get the chance to shadow a sonographer, you will learn so much about how to scan. And I think I'll second Devinder that, first of all of you who have been attending and listening in, thank you so much. And I really want to thank Alex and Jazz and Ellie and Mason. First of all, that you've gone into a specialty in a profession where you're dedicating your life to care for people. And it's an amazing specialty. It's profound responsibility, and it's a ton of work. I didn't do the 4-letter word. And so really thank you all for making that choice in life and making that choice to be, really helping in our communities. And so with that, like to each of you, just give 1 or 2 lines about ultrasound in medical education that you can share with everyone listening, with us who are trying to help be better educators for all of you. So we'll start. Alex, you're at the top of my screen. So thank you all again. Thank you all for listening. We look forward to seeing you next time. We're doing a session in family medicine, so please come back in and do that. But let's give some kudos again to our 4 panelists and future doctors. Alex, take it away.
Thanks, Peter. This was awesome. Thanks so much for having me here. Couple lines, get a probe in your hands and start scanning, put it on the patient, just practice, and ask the attendings, hey, can I scan this person? Just try and get as many reps as you can and get familiar with it, and plenty of resources out there.
Thanks, Alex. See, Mason.
Yeah, same advice. Just put the probe on the patient, scan as much as you can, try to get as much access as you can, and use it to ask a question. Say, is it this? Is it that? Okay, let's take a look at it. And if you're looking for something, you're going to be a lot more successful and you're going to find a lot more. So use it as much as you can.
Ellie, you're in the next on in the circle here. So
Yeah, thanks everyone for listening. I think if you're fortunate like me to have the opportunities to use ultrasound very easily, like, take them. Maybe it'll feel like your parents forcing you to play piano as a kid, but when you grow up, you're like, wow, I'm so glad that I did that. So definitely take advantage of anything that's available to you, ultrasound or not.
Yep. Drink the Kool-Aid, man. If you're going into a specialty and you feel like ultrasound isn't even really part of this specialty, the reason for that is because there hasn't been the data generated for it. So contribute to the body of medical knowledge by picking up a probe, finding applications within your world, your current environment, and the specialty you want to go into. And one day kids will be on Anki learning that ultrasound is the first line diagnostic therapy for the thing that you were working at. So yeah.
and with that, thank you so much. All of you are amazing. Thanks for joining. Devinder, a pleasure to work with you, and see all of you out in the listener community next month for family medicine. And in the meantime, scan, scan, scan. Take care of your patients. All right. Talk to you later.
Bye, everybody.